So I'm just going to present on a little audit we carried out at Imperial over at our Hammersmith Queen Charlotte site, and it was patient blood management on our postnatal ward. So I'm sure we're all familiar with what the definition of patient blood management is now, so I don't need to go through it. But obviously, it puts the patient at the heart of all decisions that we make. Its optimal PBM will reduce the cost and improve patient care overall and experience, and who endorse PBM as a standard of quality care. So again, I'm sure we're all familiar with the pillars of PBM. So we could act on each one in both the preoperative, intraoperative and postoperative state. And what we were aiming for in this postpartum period is restrictive transfusion strategies where the patients are administered blood on a unit by unit basis. So it was adopting a unit by unit or single unit policy, and it seeks to make each unit and every unit of blood an individual active clinical decision on the patient's situation and needs, and represents a component of Pillar 3. Far from being a one-size-fits-all, it is patient-centric with an emphasis on tailoring the transfusion to the individual patient. If the patient is assessed and reviewed, they should not be denied a necessary transfusion, but also they should not receive an unnecessary unit of blood either. So patients with clinically significant active bleeding were not suitable for a unit by unit policy and should be transfused according to their blood loss and requirements. So why is PBM important? So patient blood management programs are an extraordinary tool for the improvement of patient clinical outcomes. It can help address an important concern at the moment, which we're all familiar with, which is the shortage of donated blood, having been given the first Amber Alert for low stock back in October 2022. The current status when I'd done this presentation was a pre-Amber Alert for O neg and B neg. So hence, patient blood management is the need of the hour at the moment. So red cell transfusions in pregnancy. So blood transfusions have widely been used to treat postpartum anemia. However, inappropriate transfusions can expose our patients to unnecessary risks such as infections, overload, inappropriate wound healing, increased length of hospital stay, and hemolytic disease of the fetus and newborn. Previous audits have showed that many transfusions, especially in the postpartum period, are inappropriate and could be prevented by better antenatal monitoring and targeted use of iron supplements. So just a bit of background. So the anaesthetists I work with had done some previous audits. So I just wanted to give you some idea of why we got and why we wanted to introduce this in our postnatal setting. So one of the audits conducted when previously showed a high percentage of 2-unit red cell prescriptions. So blood prescribing behaviour was assessed postnatally. The results showed a discrepancy in prescribing behaviour with more liberal blood prescribing behaviour in our obstetricians compared to our anaesthetists. Also at this trust, we have a bit of a discrepancy with our transfusion threshold of less than 80 grams per litre compared to the nice ones, which is less than 70. And recent NATA consensus statement had advised that transfusions should be restricted to severely anemic women who deliver circulatory instability due to postpartum hemorrhage, and we should consider oral or IV iron therapy as alternatives. Another audit conducted was looking at the prevalence of anemia and blood transfusions postnatally and understanding its effects on the length of stay. So another audit our anaesthetist carried out was a retrospective audit back in February 2020, and this looked at 312 women who delivered on labour ward. What it showed was 25% of of the patients were anemic antenatally. 31% postnatal anemic patients were not given oral iron, only 10% received IV iron. 11 patients received a transfusion of which 1 unit was transfused inappropriately, and 10 patients received more than 2 units of blood, and 5 of which had no incremental HB check in between the units being given. Looking at length of stay, the average length of stay was 3 days, 9 hours for non-anemic patients compared to 3 days, 20 hours for the anemic patients, which then increased considerably to 6 days, 13 hours in patients who were transfused for postnatal anemia. So a significant length of stay for those transfused. So what they concluded was NICE had estimated that the net cost of a transfusion is 170 for the first unit and 162 for subsequent units. The cost of a normal uncomplicated delivery in the UK ranges from £620 to £1,535 postnatally. And this audit showed that the extra 11 hours in length of stay in anemic women could amount to an excess cost of over £5,000 in a month. So avoiding inappropriate transfusion through incremental HB checks could further drive this cost down. And so it was concluded that through an MDT collaboration, they wanted to improve patient blood management in our obstetric setting, which led to the development of our audit, which was in the postnatal setting. So we got together and we wrote out our aims, which was to improve patient safety and outcomes by reducing unnecessary blood transfusions and associated risks. We wanted to improve patient satisfaction by consenting patients and providing care that is tailored to the needs of the patient, so involving the patients in the decision to transfuse. We also wanted to reduce our costs, obviously, by not using blood if it was not required. So our objectives in achieving this were to develop evidence-based guidelines and protocols, so the tools that clinical staff could use so they can be tailored to the needs of the patient, and increase awareness and understanding of patient blood management principles among our healthcare staff. So really raising awareness of why we're doing this and that the tools are there to provide support in decision making as well. So the strategies we developed was to develop a multidisciplinary team of healthcare staff to lead the implementation of this PBM plan. So we involved all of our clinicians and all the nurses on the postnatal wards, got them involved from the start. And we conducted an analysis of transfusion practices and policies to identify areas of improvement. So we looked at transfusion data from the beginning of last year, from January to March, to work out what trends was going on, how many patients were transfused more than 2, how many were consented, how many patients had HB checks in between. So we had a benchmark to work against. We developed and implemented education and training programs for staff to promote awareness and understanding of patient blood management. This was obviously a forum as well to address any concerns any clinical staff had, and to ensure that they knew that they would be supported throughout the implementation of this initiative. And then we would monitor throughout our pilot period of about 3 months. We said we'd monitor transfusion practice on a week-by-week basis to see if we can identify any trends, if it's been sustained or if it was falling down, and how we would support in the interim. So the data period was a snapshot retrospective. We did an analysis of data from January to March of last year, and then done education sessions before we done the post-intervention data analysis. So we done a lot of education sessions leading up to the start of the pilot to make sure all of our clinical staff were equipped with the tools and resources they needed to sustain the implementation of this patient blood management strategy. So what can be done? So what we did was we adopted a single unit transfusion policy, very basic policy for clinical staff to follow, and it was in stable patients in the postpartum period. And it would be supported by incremental HB checks after each transfusion using a point of care testing. This was the guideline that we used, so it's from NHSBT leaflet we refer to. So the guideline was aimed at stable mothers without any symptoms such as fatigue, shortness of breath, dizziness, etc., or any evidence of cardiac disease, as well as ongoing threat of bleeding, who may not require blood transfusion in the postpartum period. Patients were consented with the risks and benefits of receiving the transfusion, and patients were given the NHSBT leaflet, which I'm sure we're all familiar with, before they received the transfusion. We also decided that we take this, it was a good opportunity to take it to a quality forum. So there was a postgrad forum teaching our postgrad teams on quality improvement techniques and methods. So we took it, we were asked if we would come along and take it to this forum, and it would be an exercise to better understand and to get their input into the challenges and barriers that we might face when we're implementing this policy. And it was already an opportunity for us to explain any challenges that we might have predicted. So we've done a SWOT analysis for strengths, weaknesses, opportunities and threats to work out what we were looking at here. So some of the strengths we identified would be improved patient outcomes, cost savings, improved resource utilization. Some of the weaknesses we identified could be resistant to change, resource constraints, lack of awareness. And that led us on to develop our opportunities, which gave us more collaboration. We could work together as a team, a multidisciplinary team. Also an opportunity to develop educational and awareness programs. And then what threats would be, how would we sustain this? Because there could be staff turnover. we know about the clinical area and workload pressures as well. So what competing priorities could there be? So we went through all this on the postgrad forum, and we discussed a COM-B model. So a model of behaviour that suggests that if we provide people with the capability, the opportunity and the motivation, then we could potentially influence a behaviour change. So all these components interact with each other to drive a behaviour change. So it's a really good forum, and we got really good engagement from the postgrad team. A lot of it we were aware of afterwards anyway, but I think for them to see it and to feedback was really, really helpful as well to us. So the data collection, the markers that we knew we'd be able to analyse, we agreed on that the doctors prescribing must document each of the following in the patient notes. So they needed to have documented that the patient was consented, the reason the patient was having the transfusion, the number of red cells that were going to be transfused, and the lab HB result, and then the HemoCue, the point of care testing result in between each unit being transfused if subsequent units were to be transfused. And we developed sheets and all this and left it next to the machine, so it was easily accessible to all staff. They weren't having to go anywhere to find this documentation, so it was all kept in a tray together. And next was a point of care testing machine. So this is the HemoCue, and this is what we agreed we would use for our point of care testing. Now, there was one on our labour ward already, but weirdly we weren't allowed to use it because it hadn't been validated for what we were attempting to do. So we contacted the HemoCue reps, and they very kindly loaned us a HemoCue, originally for a month, but they ended up letting us take it for 3 months for the whole study period. We had to go to point of care to fill in an application form. It had to be approved by our point of care committee in order to get the green light to go ahead. We then had to work out consumables and who was going to pay for the consumables for this. So it was agreed that our postnatal ward would be paying for this. And we needed to get all these in to test and validate and make sure that we could actually train staff to do it as well. So once we had agreed, we then done some education sessions. So we set up weekly, for the first week we set up daily education sessions, then we moved them to weekly, and then we moved them to every time there was new staff, we would be doing training sessions. So the protocol, going through the protocol and decision-making tools to enable this decisions to be made, teaching people how to use the HemoCue. And it's crazy how people love to stab themselves to find out their HB. They were all on for it. And also, as I said earlier, it was a forum to address any concerns that the team may have, to ensure that they felt supported, and to ensure that we would be on hand if there was any problems, that we would be on hand to answer and address them as well. So the results showed, so we ran it for a 3-month period, and then we looked at the data every week. From the pre-intervention pilot, so back in January to March, we asked Path IT to give us the information, and they gave us 1,433 patients, which we then had to really filter down to work out how many of those patients. This was our whole Queen Charlotte's, which is maternity, gynae, neonatal. So we had to filter out all of our obstetric patients, and then we had to filter that down to how many patients actually had more than 2 units. So it actually turned out to be in the postnatal setting, and it actually turned out to be quite low numbers. So in our pre-intervention period, back in January to March, we had 23 patients who we felt could be included in this pilot, compared to August to November of our actual audit, which was 20 patients. So the results are here. So patients consented, so it increased slightly in August to November. The number of patients transfused 1 unit was just slightly lower, and those transfused 2 units, again slightly lower, and those transfused 3 units was just slightly up to 10%. The biggest difference was in the HB checked in between each subsequent unit, which went from 4% up to 60%, which was great. And then the average incremental HB went from 93 and reduced down to 91. So what we concluded was that there was a vast improvement in consenting patients for blood transfusion, a slight improvement, sorry, in patients for blood transfusion post-intervention. There was a slight reduction in patients transfused and dose transfused multiple units. However, this difference was quite small. The average incremental HB was also slightly reduced in the post-intervention group, but not to a significant degree. There was a good uptake of checking HB levels in between transfusing subsequent units. So this went from 4% up to 60%, which was brilliant. And so what we needed to do is we need to work on educating incoming doctors and midwives to ensure that this 1 unit policy can be sustained. So we've set up correspondence with the lead midwives on the ward, and every time there's new midwives, We are informed so we can arrange an education session, just as when the cohort of doctors change every couple of months, we're contacted and get them on their induction to go through this to make sure that everyone's equipped and ready to go. We had to give back the machine, the loan machine, and it transpires that the HemoCue machine that was originally on labour ward that wasn't being used was redeployed up to our postnatal ward, so they had a machine ready to go that they could use. So we've managed to sustain this project with the education training and the tools required. So what was next for Hammersmith? So this was evidence to build a case for a standalone IV iron service at our Hammersmith site. So we have 3 sites, which is St Mary's, Charing Cross and Hammersmith, and St Mary's and Charing Cross both have IV iron services, but Hammersmith don't. So our anaesthetists are really keen to get this up and running, and they've passed on this information. They've shared this information among their other anaesthetic colleagues who have in cardiac have conducted a surgery showing a significant difference in length of stay versus anemia versus non-anemia in the peri-op period. So there's really good work being done to really prove that we do need this IV iron service at our Hammersmith site. We provided our teams with lots of resources. I'm sure most of you are familiar. So we'd lots of all the resources on e-learning for health, etc. We showed them where the leaflets were. We had great encouragement from our clinical teams. They were really keen to get involved in this and to learn a lot more about it. And obviously there was toolkits available. Our obstetric anaesthetists gave all their clinical counterparts all the tools they needed to be familiar with the techniques that we were going to be using as well. So I'd just like to acknowledge my 2 colleagues who I worked with on this, Karen and Sonali. Karen was actually meant to present with me, but she moved back to Malta and had a conflicting work issue that she couldn't join. But a lot of the data as well that led up to our audit was conducted by both of these prior to the start of this audit. And that's it. Thank you very much.